Okay, so today, our session, we are growing, learning, and changing today. So our first speaker is Mandy Cornelius. She's from Mayo Clinic Health System in Wisconsin, and her title is Improving Communication and Teamwork in the Cardiovascular Surgery Operating Room. Welcome, Mandy.
Thank you. And as she said, my name is Mandy Cornelius. I'll be presenting communication and teamwork in the cardiovascular surgery operating room. Now, this presentation is meant to augment the existing communication and teamwork already in your teams and offering strategies in how to improve that. Disclosures. I have no disclosures. So by a show of hands, how many of you took an airplane to get to this conference? Wow. Almost all of you. Well, that's good because today I will be talking about safety in aviation and how it's been often compared with safety in healthcare. And I'll be reviewing the similarities and differences between the aviation and healthcare, specifically communication, and the application of these lessons learned in aviation to healthcare, and that's specifically for our cardiovascular OR teams. So currently, there's only 207 fatalities for commercial airlines per year, whereas in medical, there's about 251,000 preventable fatalities a year. This is equivalent to about 3 airline crashes a day. That's about 900 people dying a day in the United States. Now, aviation wasn't always safe. In the 1970s, 70% of the crashes were due to human errors, not the equipment and not the forecasts or the weather. So they brought in something new. They brought in psychologists. They focused on new training. This training focused on group dynamics, leadership, communication, and decision-making. And that led to the aviation being the safest mode of transportation in the world today. So how comparable are these two industries? Aviation is centralized and is governed by the national authority called the Federal Aviation Administration, the FAA. And they have comprehensive responsibility for personal licensing, the equipment certification, the facilities, and the operator certification. Healthcare is decentralized and dispersed. For example, in perfusion, there are multiple and separate entities. You have the national board and accredited perfusion schools, and there's no reciprocities from foreign countries. Then you have the state licensures, and perfusionists may or may not be licensed in the state that they work in. Regardless, they still can practice. In addition, you follow Joint Commission rules. The government has the FDA, and the government also controls with Medicare and Medicaid. And these two entities do not communicate with each other. They're in separate governmental silos. So healthcare may never be as ultra safe as aviation, but that's only if nothing changes. Healthcare has close personal contact that aviation does not have. So this also results in bypassing protocols, barriers, and safeguards with the patient's best interests at heart. So in both aviation and medical, human errors and/or communication failures cause or contribute to the most adverse events. However, aviation is highly federally regulated. The medical is not. This causes leeway for adverse events to occur. So this is a table showing the distinctive features of aviation and healthcare. The aviation is in the blue column, healthcare is in the red column, and on the far left, you have their domains. And I'll just be pointing out a couple of these domains. In the activity domain, pilots operate 1 to 2 types of aircraft, and the episode usually lasts 1 to 10 hours with the same crew on board. Whereas in healthcare professionals have to deal with a wide variety of equipment, diseases, and presentations. Duration of the inpatient stay may be days or even years, and the numerous changeovers of staff. Down in equipment, there is a degree of standardization of displays across the aircraft that they use, and most of the procedures are automated with multiple backup systems. While in healthcare, there's relatively little standardization of design across medical equipment. And automation of procedures and backup systems are somewhat variable, with much healthcare being hands-on. Finally, down in the service delivery category, aviation is more homogeneous, whereas healthcare obviously is heterogeneous, with a number of subspecialties involved, including cardiac surgery. So overall, aviation has the same crew, short periods of time. Healthcare has multiple crew with longer periods of time. And aviation deals with 1 to 2 types of equipment versus healthcare in a variety of situations. Furthermore, in this table, there are safeguards. In aviation, safeguards are in place with high degree of automation and computerized support, and there are strictly enforceable rules to exclude adverse events of fatigue. Where in healthcare, there's limited safeguards, hands-on work, and a relatively lack of automation, and they lack strictly enforceable rules to exclude fatigue. In the domain of adverse events, in the aviation community, major adverse events are always investigated by a national body. These events are often featured in the media, and pilot immunity is often part of the reporting culture. In addition, adverse event investigation reports are always published. Whereas in healthcare, major adverse events are usually only investigated locally, they rarely make the news, and immunity is not necessarily part of the reporting culture, and disciplinary procedures are wide-ranging. Not all adverse event investigation reports are published. Summing this up, high automation versus hands-on work with healthcare, and aviation has strict rules versus lack of rules on fatigue. Aviation adverse events are always investigated and published versus locally seldom published. In addition, immunity is guaranteed for the pilot versus wide-ranging disciplinary procedures for healthcare. So why does this matter? Although patient safety in the operating room has improved in the last decades, significant risks remain. We all know that. Adverse events may occur that are subtle and delayed, like waiting for those blood products or delayed orders, or something dramatic and immediate, dealing with miscommunication. Over in the right-hand side, studies show that communication failures are the cause of 80% of adverse events in surgical teams. So since human errors and communication failures cause most adverse events. So to understand how to improve, let's lean against decades of aviation history and its always improving safety record. So in its simplest form, the pilot is to the cockpit as the surgeon is to the operating room, and they all get the people the care that they need. But do these experts save the day by themselves? The surgeon might say, oh yeah, I totally got that. I saved the patient, I saved the day. Same with the surgeon. What about the perfusionist? The surgeon works in concert with highly intelligent teams. That includes a perfusionist. And that's what separates us from all the other surgeries, because we do open heart surgery and you can't do it without us. It's necessary to work as a team. So we work in highly specialized teams as individuals. In airlines, we have the captain, the first officer, crew, flight attendants, flight mechanics, ground support, flight planning, and air traffic control. All of those support you getting to another destination on time. In the medical field, cardiovascular surgery, you have the surgeon, the first assist, the surgical tech, circulating nurse, anesthesiologist, and perfusionist. and they all help get the patient the new valve or cabbage done. But we all work in silos. How do we communicate? Especially when we don't know what anybody else does. We generally know, but do we need to know more? Do we need to know the science and the theory behind what the anesthesiologist is doing and why they're doing? No, we don't need to know that, but we need to have a checklist and we need to know what they're doing and what they're doing to the point that they've got it done and it's been done correctly. And we can go on further in the surgery. So healthcare is tightly coupled. So the complexity of the connections across the physician-patient system enables nonlinear movement of vital information. This creates alternate pathways to vital information and prevents key people from having the information necessary for them to make these decisions. And these critical decisions are likely to be made in rapid succession without verification. And when this happens, obviously I'm describing the Swiss cheese model. You've got the hazards in the far left, and all the plates or the holes line up, and it goes through the organization, the controls that are in place, the work processes, finally the people, and that's how you get an accident or incident. I'll give you an example. As a female patient came in for an AVR and a cabbage, 1.65 BSA, came in on a Sunday. Surgery was scheduled for Monday. They did pre-bypass labs the night before. The blood gas came back, hemoglobin 6.8. So that triggered a control in the blood gas lab. Okay, let's type and cross. And unfortunately, this patient had a rare red blood cell antibody. All right, how much blood do we have? We only have 2 units in the entire county. Okay, let's get more blood. We have to call across state lines. Let's order some blood. How much blood do we need? When is it going to get here? Can we proceed with surgery? Is 2 units enough? Surgeon still wants to operate. The PA says, hold on, let's talk to people that use blood. Let's talk to the anesthesiologist. Let's talk to the perfusion. Are you comfortable operating knowing that there's only 2 units of blood? And we've got blood on order, but we don't know when it's coming in. It's coming in from 2 hours ago, from a 2-hour estimated time. It has to be driven. You can see how each one of these are separate holes, separate plates that if surgery would happen, what about if we saw the chest and bleeding started to occur? We're going to need more blood. Heck, I'm going to go on bypass. If she's at 6.8, I'm not going to go on bypass without giving blood anyways. There's no way that I can keep her at a hemoglobin of 8 or higher if she starts at a 6.8. So this is just one example of how potential accidents can occur. And we know that the impact of poor teamwork on patient outcomes is, and we know that impact of poor teamwork. Patients whose surgical teams exhibited fewer teamwork behaviors were at higher risk for death or complications. So there's a direct link between teamwork and patient outcomes. Culture is important. So human factors, each of us, is the last safety gate in the Swiss cheese model, but it's also the most vulnerable. In this figure to your right, you have 2 sets of factors. You have the latent factors. It's your culture. It's in the background. It's always there. It will never change. You've got the national culture, and goes all the way down to your team culture. It's slow to evolve. And then you have the active factors. These active factors are your dynamic environmental factors, etc. These are where your mistakes and your violations and lapses in judgment will occur. They're your abrupt and surprised events. And in aviation, they do a performance analysis. The performance analysis, now you can tell it's a neutral term because they know that everybody at this form is operating at high levels of excellence. They want to look at both positive behaviors, like, hey, that worked, let's continue to implement that, or that obviously didn't work, the negative behaviors, and let's see why that happened and not do it again. So if you're not a high-performing team, how can we improve ourselves? So maybe you lack performance because you don't report errors systematically. If there are errors, do you guys put it into a computer? Do you have something internally? Or do you take these examples and talk to your teammates? Do you have time for investigations? Do you have time to put lessons together from these investigations? And do you implement the changes from the lessons learned? If you don't, because you probably don't have them. So how can you have a high level of performance if we don't report the errors, complete investigations, learn from the errors by implementing the changes? The blame game. So historically, aviation was, like medical field right now, a blaming culture, but eventually evolved to a reporting and then just culture. And how did they do that? Well, they know that every person contains vital information. So the person that commits the error holds vital information about the preconditions leading up to the error. The individual is protected and encouraged to share any error or near misses without losing his or her job. And sharing is helping, not only at a local level, but across the global level. So the lessons learned are systemically shared across the industry based on the systematic investigation. So what's happening in perfusion nowadays? So our actual leaders, I would argue that they are our physicians. When we talk about investigations or errors, communication, adverse events, when we bring it to them, most likely they're going to be absent from this process. And that's because they have no time, they're too busy, it's not a priority. In addition, there's no analysis occurring and no feedback. So aviation focuses on specific improvements resulting from the incident reports rather than measuring success based on the number of reports received. No improvements can occur in this situation if no specific improvements are identified. All right, dual data collection. I think everybody who has a computerized health record may be approaching this point. So we know that we get a lot of data, and chart review and independent observation are not new and they are expensive. However, in the aviation community, data is always collected while in operation and it's automatically analyzed. This is called the flight operational quality assurance. But there's two tiers of data. So they have, on the human side, the incident reports are completed by pilots for anything that they consider to be of concern. And then the data that is automatically captured, the data that falls outside the predetermined parameters is flagged. So for example, if you were pumping a case, the surgeon said, go down on flow, you're down on flow, there's numbers. A lot of times you can put a little timestamp there that it says, okay, down on flow per surgeon. And so when that set of data is flagged, you can tell, okay, that was for a reason. It wasn't just because the perfusionist walked away and bumped the knob. So this dual data collection combines self-reported incident data containing contextual and intentional information with the automated data collection and analysis. This is having the black box and the pilot to understand the big picture. In addition, does all of your equipment transmit data? We use a lot of equipment. We use ECMO, balloon pumps, CDI 500. We use the TAG. Do all of those talk to each other, and do they have time? Are they synchronized? Do they report the same amount of information in the same set of sequences? Because we all know that when we're behind the heart-lung machine, that errors happen quickly. Does data capture that? And are we able to log the important events? And are these events integrated into the data when they're being able to analyze? Or do you have a separate sheet of data? I noticed that the perfusionist went down on flow. Okay, now we have to go back to the database and see, oh yeah, we know that they were down on flow and it was purposeful. So the perfusion viewpoint. Perfusion has a back row seat to the operation at hand. Often we follow a live video stream or the headset is on the surgeon's head and we can view from what they see for situational awareness. If not available, the perfusionist gleans information from the tools passed between the surgeon and the surgical techs. How many times do you tell the surgeon what he wants to hear and not what is actually happening because he can't see, doesn't know what you're doing back there? This is anesthesia's viewpoint. This is metaphorical and literally a physical barrier in addition to face masks. And the surgeon's viewpoint. Is this the big picture? Is the surgeon able to be the team leader from this narrow point of view? Yes, everything in the entire room goes to support the surgeon's process of repairing this aorta and valve, but can he appropriately combine a team and keep everyone on the same page? So this is the problem, the challenges of effective communication. So we know operating rooms are chaotic and noisy environments. Visual and audio cues are hard to see and hear when people are wearing masks, and the general public got to experience this during COVID-19. And the person that's identified to act on information isn't always clearly identified. There's no standard operating procedure. And maybe there's an invisible hierarchy. We all encountered people with ranging age, rank, years of service. And what is the big picture? Perfusion is relayed changes by surgical techs or anesthesiologists instead of the surgeon. This is a less than effective form of communication and misinformation and can be wrongly interpreted. So direct communication is the only reliable way to communicate in real time. For all those vendors out there, maybe you can create like an intercom also so I can hear the surgeon when he does communicate to me. So humans innately want to look good. This is a fact. This comes from many forms such as rejecting standard operating procedures because they're experienced. They don't need an SOP. I've done hundreds of these cases. Maybe it's being embarrassed or feeling stupid, being wrong. Maybe you don't want to say something that's stupid. These are all stories we tell ourselves, even though that we are smart and skilled individuals and are trained for this task. So we must make this an OR a safe environment. Get rid of those toxic behaviors. Feel free to advocate so we can speak up for the patient. And we must be able to be willing to keep open communication in case of conflict or difference of opinion, even then. So how did we get here? Historically, the personalities drawn to these careers and through educational selection and training demand independence, motivation, and confidence. When and where is there a team focus? So in your educational training, was there class focused on effective communication, decision-making, leadership, and/or teamwork? These are not all innate qualities. We are all nerds. Science is our language. Aviation's solution was to incorporate crew resource management, and is based on a set of principles: situational awareness, communication, leadership, awareness, adaptability, and CRM aims to improve communication skills and behavior among members. They encourage sharing a mental plan. You may have heard of this. It is called Team Steps. So even with the best surgeon in the world and the best anesthesiologist and the best perfusionist, I'm talking about each one of you because we all know we're the best, the operation will fail because you cannot coordinate or communicate. So in your teams, how often do you practice with your teams or multiple teams because of shift change? Teamwork is about how the work gets done, and teams do it better by 20%. And how often are teams willing to speak up, acknowledge mistakes and questions? Psychological safety is the #1 predictor of team performance, and it's helpful for leaders to admit when they're wrong. How often do you brief and debrief with your team? Teams that conduct well-designed debriefs perform an average of 25% better than other teams. And I'm not talking about, okay, everyone, let's sit down and look at each other and talk about this. No, a quick huddle, debrief, Couple sentences. Everybody's on the same page? Great. Let's not do this again, or let's do this again for a specific procedure. Are there standard operating procedures for every procedure? A shared mental model among team members. The team is set up to collaborate and succeed. And in addition, how often do you practice emergency procedures to the extent that they become non-events? These non-events open up time so that if other unexpected events show up, you're ready for them. And how often do you check to make sure that all the emergency equipment is ready? I'm talking about not only the heart-lung machine, but the ECMO machines, but also that empty, or could be empty, oxygen cylinder in the back waiting for that maybe oxygenator underperformance or exchange. So a delay is better than a disaster. That's from Captain Sully, who landed flight 1549 in 2009 by landing in the New York Hudson River. So high-performing teams. We are all highly functioning individuals working in a multidisciplinary team, but are you high-performing? Do you have shared mental models, clear roles and responsibilities, optimizing resources, strong team leadership? The importance of SOPs. How many times must we repeat an error before we learn from it? What if we didn't make that error at all? And the process repeats itself. So to make my point, the standard operating procedures. If it was written down, if the wildebeest had already known that that log is a crocodile, he wouldn't have to find out the hard way. And then the process would not repeat itself. In other words, an SOP needs to be written down and followed without improvising to transmit knowledge. So on the national level, perfusion is making strides. AMSECT, the American Society for Extracorporeal Technology. So AMSECT has new clinical protocols on their clinical resource page. These are a variety of protocols in published literature. They can be used as framework, or maybe they can complement what you already have established. And it's free. Perfusion loves free. Industry loves free. And it's readily accessible. Just to take a moment, go to amsec.org, scroll over to the policy and practice on the far right side, highlight on perfusion clinical resources, and up pops an entire page with clinical practice guidelines and clinical protocols. They also go as far as developing pediatric clinical protocols, and guess what? There's also an implementation toolkit. So you don't have to reinvent the wheel. There's already a framework lined out for you. So in Mayo Clinic Healthcare System, I'm representing Eau Claire and Rochester, Minnesota. So this is just a small way to organize some of your SOPs. Currently, there's 67 that are listed here, but there's probably hundreds. And the human factors. So in Rochester, Minnesota, there are 15 surgeons. And despite our best efforts to standardize across the surgeons, we had to make a preference and procedure guide. So there's 95 pages of preferences for 15 surgeons with pictures, graphs, links, etc. For example, there's one surgeon that says flush the noodle. 1 out of 15 uses that frame of work, of speech. In the middle of the night, you're gonna like flush the noodle. What the heck? Oh yeah. That's the guy that says give cardioplegia. In aviation, no margin for interpretation. So all of this that's currently implemented would not be accepted because all pilots and crew communicate using the same language and structure. So you can put any pilot with any first officer and any air traffic controller who have never met before, and they will accomplish their tasks with the highest safety standard possible and understand each other perfectly. Can you imagine our surgeons or your surgeons and staff doing that? So even if you have SOPs, some teams fail to follow them. Here are a few reasons that may contribute to that. Procedures misaligned with operational situations, workload preventing completion of the procedures, procedures that are too prescriptive or detailed, or maybe there's no adverse consequences. I can do whatever I want. No one's going to do anything to me. I'm going to skip this slide real quick due to time. So in conclusion, the recipe for success. So crew resource management enables teamwork and effective communication. Standard operating procedures. Hey, if you don't have any, AMSECT has some for you. And maybe you can adapt some of your information from theirs. And standardize equipment as much as possible. Communicate, effective communication in the OR, using standard vocabulary. And is there a leader? Is that leader busy? Maybe we need to find another leader. And is there a just culture instead of a blame culture? Report errors or near misses systematically. Data collection improvement. Combine those with your crew reports to get the entire picture. And data doesn't tell everything. And analyze these accidents or near misses, lessons to share, and share them nationwide. And provide individuals time to fill out these reports right away while it's still fresh, not pushing it off to after hours or when you're done. Okay, we'll get around to it maybe tomorrow. So don't reinvent the wheel. Steal from successful safety aviation and industry practices. Do you guys have any questions?